Welcome, everybody, to episode 2 of the No Normal Show for Thursday, July 2nd, 2020, brought to you by Revive Health. This is our weekly deep dive into how hospital and health system marketers can navigate what we call the no normal. I am Chris Bevelo, Health Systems Practice Lead at Revive Health and your host for the show. I am joined by Chase Kleckner, Senior Marketing Manager at Revive Health and our show's producer. Hello, Chase.
Hey, Chris. Good to see you.
Good to see you as well. We are also joined by Paul Matsen, CMO at the Cleveland Clinic. Paul joined Cleveland Clinic in 2006, and he is responsible for all marketing communications programs at the Cleveland Clinic, including global development of the brand, marketing of key clinical service lines, regional and international locations, and digital marketing. He also leads Cleveland Clinic's corporate communications department. Prior to joining Cleveland Clinic, Paul was most recently the Executive Vice President and Chief Marketing Officer at Delta Airlines for 12 years. Paul, how are you?
I'm doing well, Chris. It's good to be with you again.
Yeah, thanks so much for coming back. We really appreciate you having on, and we're looking forward to diving in. In fact, we're gonna ask you first about that Delta reference when we get diving in, so be ready. Just a couple of notes before we get started. If you're new to the podcast and are wondering what we mean by the no normal, check out episode 1 or read a blog post that we have at thinkrevivehealth.com that includes the no normal title. Chase will also post a link to that blog post and episode 1 in the chat function. Essentially, any kind of new normal is not around the corner from our perspective. We're likely living in this state of uncertainty for months or maybe even years, as Paul might allude to here in a little bit. And as hospital and health system marketers, we have to learn how to adapt and thrive in that environment of uncertainty. So that's what this show is all about. We'll be sharing industry trends, research, stories from those within and outside of the health system industry. Also sharing other ideas and content to help you all navigate the no normal successfully. As we move through the show, we want this to be as interactive as possible. So if you have a question for Paul or myself or Chase, use the Q&A queue in Zoom. Just put your question in there. We'll definitely have time at the end of the show to go over questions that are posed there, or we may tackle them as we go through. You can also use that chat function I mentioned a little bit ago if you want to communicate with other attendees. Chase will be using that to post links to things we're referencing. But if you need us to answer a question, make sure you put it in that Q&A queue because we're monitoring that for questions. Remember also, you can subscribe to the podcast on iTunes or wherever you listen to podcasts. We also post a recording of the show every day at our website at thinkrevivehealth.com. Go specifically to thinkrevivehealth.com/COVID-19 for that. All right. One more thing to kind of let you know about before we start diving in. We have a new paper out, 5 core issues for providers post-COVID-19, co-authored by Revive Health and our partners at Denton's, the world's largest law firm. Definitely check that out. That is at our website as well. Chase will post a link to that. So Paul, let's start because you all at Cleveland Clinic have a pretty healthy presence in Florida. We know Florida is one of the hot spots in our new wave, or whatever we're calling this, the continuation of the first wave, the new bump. There's all kinds of names for it. I believe they announced exceeding 10,000 cases yesterday, which would be a new daily record for them. Do you want to talk a little bit about what you're hearing and seeing from your spots on the ground there?
Sure. Yeah. I mean, for the folks listening in, we have a hospital in Weston, Florida, which is in Broward County, just north of Dade County, where Miami is. And then we have 4 hospitals north of Palm Beach, 3 in Martin County and 1 in Indian River County. So we are seeing statewide a rise in cases, and that's certainly hitting Miami-Dade the hardest. And they announced this week that they're closing all the beaches there for the weekend, at least, and possibly longer. I think they're putting restrictions in place on bars and the serving of alcohol again in the state as well. We are seeing a rise in cases. We're seeing a rise in positive tests, but so far we've only seen a mild rise in hospitalizations. And I think what we're hearing around the country, we're hearing it in Texas and Arizona, is this is affecting younger people who are getting exposed. I think we're seeing behaviors among older populations are more responsible. They're masking, they're still distancing more effectively. In Ohio, we've also seen a rise in cases. Ohio has really been a success story under the leadership of Governor DeWine. And we reopened early May, but we've seen a spike in recent weeks. And we're seeing hotspots in certain parts of the states, down particularly in the southwest part of Ohio. And the city of Dayton just put mandatory masking in place. So we're in contact and coordinating with the State Department of Health daily here and in Florida. And I think so far we don't see a hospitalization trend that would exceed our ability to manage it across the state. And the strategies now are really doing the basics of communications around masking, distancing, hand hygiene, and testing, really going in and testing hotspots as quickly as possible. So, hopefully this 4th of July holiday weekend won't lead to another huge spike. But the other thing to note is mortality rates are coming down because it is affecting the younger population, but certainly concerning for everybody.
Yeah, it's kind of weird for us because we started when this all started in March, we started a daily podcast that was just about, hey, it was brand new, obviously, for everybody. There seemed to be a need for ongoing, counsel, sharing stories, sharing best practices as we got through it. And we hit a point, I think, in late May or early June, where we thought, the need for daily updates on this is really kind of waning. And that's where we decided to switch to this podcast, where we try to take a deeper dive into things, but also why we call it the no normal, because what's happening now just shows this is not something that's going to settle. We're nowhere near something that looks like normality. And this just is showing us again that it's just this uncertain state. And I think that's what we wanted to ask you about, because, your experience prior to entering healthcare, you were at Delta, you were in the airline industry when we all had maybe the last event that's even close to something like this in terms of societal impact, which was 9/11. And so when we talked before, you mentioned a little bit about, from your perspective, how long it took really to see what we would consider normalcy just for the travel industry. Maybe you want to speak to that just a little bit.
Yeah, I mean, I think everyone remembers, regardless of where you were, what age or stage of life you were, that that event and what a shock it was to the national psyche and normal life. And literally the air travel system in the United States shut down for 4 days completely. Airplanes were put on the ground. People were remained in place. We had employees all over the world. We couldn't get home. We had to account for all of our people. That was an incredibly challenging time. And then, actions were taken, security processes were changed, aircraft cockpit doors were hardened. Behind the scenes, a lot of technology was deployed to track travelers, and gradually travel resumed. But I would say, that was 9/11, 2001. It probably wasn't until after the financial crisis of 2008 that the industry fully recovered. In 6 of the 7 major airlines in the U.S., every airline except Southwest that's classified as a major went bankrupt, Chapter 11. And then years later, it took the big 6 merged into the big 3. And now since then, the industry has had record profits. We've had record levels of international travel, and a new normal was achieved in terms of people's comfort with travel. But I think a couple of lessons from that. One, I think we're going to see substantial financial impacts. Hospitals haven't begun reporting yet to bond rating agencies, but that'll happen in July. I think we're going to see substantial impacts across the industry. I was mentioning to you, I saw the president of the American Hospital Association yesterday speaking about losses for the industry monthly in excess of $20 billion. So it's staggering. I think it'll lead to structural change in the industry. We've seen a lot of consolidation in healthcare. It's a lot of stress on rural hospitals, a lot of stress on independent hospitals that don't have the balance sheet. And I think we could see industry restructuring down the road as well. Obviously, people talk about the changes that'll come from things like telemedicine, but I think people need to recognize it's going to take time. And like the airline industry, we are a business with very thin margins. So getting back to where we were in terms of volume and finding growth again is going to be essential. I think all I would say reflecting back was it challenged all of our pre-9/11 thinking. Things that had never been on the table before were on the table, and in ways that you couldn't have imagined. So I think for all of us, we're going to have to be prepared to be nimble and think differently.
Yeah, that is all, kind of right on in terms of healthcare. And then you think again, like we think about 9/11 and the impact on the travel industry. It impacted other things too, but that was where the most profound impact was. Obviously, healthcare is at the forefront of this pandemic, but it is impacting society in ways that go far beyond healthcare.
Yeah.
And that's the other side of it, is consumer behavior, the economic impact of this. And we saw relative good news on unemployment, but we know that's not going to, we're not going to get back to where we were by August or September. And if things like the Florida news and Texas news continue, it could get worse again. Those things are going to also take a long time to settle in, for behaviors to kind of normalize, and then for us to understand what those mean. So it's just, we're in it for a long haul, and we just have to be really
we're working with employers and businesses across the country, around the world, on reopening strategies, most notably, interestingly, United Airlines. Mayo Clinic has now announced they're working with Delta. But we've worked with United on a program called Clean Plus, because they have to rebuild confidence of getting back on an airplane, setting scientifically based standards. And in some respect, to your point about healthcare is definitely affected, travel has probably been affected worse by COVID than it was by 9/11, ironically, because you could see that threat. It was a known threat. And here, we don't know when we're going to have a vaccine or treatments that are highly effective. The only thing we know for sure is the behaviors that can prevent the spread. And I will say hospitals in particular, and we've been messaging this very heavily, have become very safe environments because we've adopted all of those behaviors. Our percentage of caregivers who've been infected since COVID began is less than 1%, and we trace and track them all, and most of it is community spread. But businesses need to adopt similar practices. Businesses, schools, any place where people get together.
Well, I like what you said about when you're in the airline industry, the 9/11 caused you to think about things that you would never imagined. I was playing this out with a colleague the other day, thinking about just, I have, my wife and I have 2 cars in our family, always had 2 cars. One of those cars has been, basically there's a coat of dust on it. We just haven't used it. There's no reason to have used it. We've gotten used to not going out as much. We've gotten used to having things brought to us. So like if you're in a delivery business, frontline worker now, bringing food or bringing deliveries, whatever, will that go back? Or will we get to a point where we decide, like, why do we even need a second car? And then the implications on that for the auto industry, right? So it's things like that when you just start taking like 2 or 3 degrees away and you go, oh, wow, like the impact of that on healthcare, if you circle it back around. And so anyway, it's going to be.
Sorry, my landline phone is ringing in the background, but maybe you can't hear it, talking about old technology. But I think, I think one of the keys is not to try to make too many long-term judgments based on the present. We're still to use a bad cliche, in the fog of war. We're debating right now administrative space and people coming back to work, and all of our administrative non-clinical staff is working from home. But how will that look 6 months from now, 12 months from now? How will people feel about it emotionally? How will they feel when their kids are back to school and there's normalcy again in terms of childcare? In the travel behavior, it took time, but eventually people not only got back to normal, but blew right through it. I mean, global travel in the last decade has exploded to places people never went before.
Yeah.
But, for sure, we've seen, we'll talk about this, I'm sure, some other questions, but we've seen this dramatic growth of virtual medicine. We're seeing it settle back down at a higher level than before, but not at peak COVID levels. But, so I think we're so early in this. I think we're going to have to learn to live with COVID. And it's not just going to be an episode. It's something we're going to be living with for some time.
Yeah. Yep. Totally agreed. So let's talk a little bit about, less about, well, I think you can talk a little bit about how you all responded during COVID-19, but I think it's more important to think about it in terms of maybe what you've learned from what happened, at least during the first wave, March and April into May, and what the biggest takeaways are for you moving forward.
Yeah, I'll just say some broad organizational thoughts, and then I'll zoom into communications and marketing. But we really had COVID on our radar starting in January. Because we're a global organization, our first experience with COVID actually was in Abu Dhabi, and they saw the first patients. And we rapidly began to assimilate that learning through our incident command structure, which includes all of our locations in Ohio and Florida, Canada, Vegas, around the world. And so we started our early planning in January, including looking at clinical processes, looking at surge capacity, and building up stockpiles of PPE. And we really went through some distinct phases. First, the early phase where we were standing up drive-through testing and trying to, really aggressively build testing capacity. Then it was building surge capacity, and we took our brand new education building with Case Western Reserve University and turned it into a 1,000-bed surge hospital, which positively ended up never seeing a patient. Right. We call it the Hope Hospital. Then we pivoted seemingly relatively quickly to recovery and reopening. And now we're in this sustainment phase and trying to get back, to pre-COVID levels, but managing now these flare-ups and spikes that are happening. I would say, pivoting to the marketing side, you and I have talked over the years about digital, and you've been a leading voice in encouraging healthcare organizations to get out of the traditional and build digital capabilities. All of that came into full view during the COVID crisis. Yeah. Our digital platforms, our owned media platforms, have just exploded in terms of growth, and they've had a big impact. I mean, we're reaching consumers and patients in our communities and all over the world. So, just as an example, and it's always good to have some numbers, since March 13th, which for us we defined as the start of our COVID patients, we've done 8,000 social media posts with 130 million impressions. It had 62,000 comments and questions. Wow. Our website this year, last year we finished the year just shy of 200 million sessions. We've already done 127 million sessions so far this year, so we'll exceed 250 million for the year. We're seeing similar growth on our podcasting platforms. We're providing 1 million emails a week, updating people weekly on developments and answering questions that we're receiving from them through our contact channels. We have done some traditional television. Yes, we've done a lot of earned media, and most of that's going out through our newsroom and social platforms, but some traditional earned media. But the digital platforms, we've seen their full impact in the last 100+ days. And that's on the external side. We can talk a bit later about the internal, where we've seen similar incredible impacts from internal digital media.
Yeah, which is so important. The internal side is so important. So let's save that. Talk a little bit about, you mentioned, now you're in the recovery mode, however you want to put that, trying to get people back into the hospitals and into the physician offices. talk a little bit about how you're approaching that, what you've seen in terms of what we all know at this point, which is people are really reticent to come back in to different degrees, but that's been a huge challenge. There was a story today, I think, in the Washington Post that talked about the thousands of deaths that are related to the pandemic, but not from COVID-19, but from people not coming into the hospital when they should have. So talk about what you guys are doing in that regard.
Yeah, our CEO, Tom Mihaljevic, co-authored an op-ed for the New York Times with the CEO of Mayo Clinic, Gianrico Farrugia, on exactly that subject, the mortality effect of delayed people coming in for strokes, heart attacks, cancer screenings. I will say we went out and conducted our own primary research during the month of April and early May. We're going back out shortly after the 4th of July weekend for another round of consumer research to have our own pulse on perceptions. Clearly, safety is number one. And people are much more willing to come back for higher acuity, more complex care. They want to come back and see their cardiologist, their oncologist. There's more resistance to coming back for routine care. And we've also downsized our outpatient spaces to allow for social distancing. So we're running at about 75% outpatient capacity, but we're making that up with virtual visits now and building that into the business model. So that's one of the big learnings and wins out of this process. But we're also seeing people not wanting to come back for orthopedics. You know, that's much more discretionary. People are willing to live with the pain a little longer. So that's an area of some softness. But generally, we're seeing very good recovery. We actually, for the first time in my career, we did 2 TV spots with our CEO right at the beginning of May. We specially produced them with him talking to the community about safety and thanking the community for their support. And we've gotten a lot of great feedback on that because, you know, hearing from him directly as a leader and addressing safety head on. The other thing is in your facilities, and I know health systems around the country are doing this, you know, universal masking. We now mask all visitors, we mask all caregivers, thermal screenings at all the entrances, disinfectant and cleaning programs, making that all available publicly for people, and continuing to reinforce that. That's going to be with us for some time. So we've seen a very nice recovery. You know, we're seeing a recovery at levels that are exceeding our expectations right now. We're still not back to 100%. I think we believe that's going to take several more months, if, you know, hopefully by the end of the year. But we're very encouraged by what we're seeing. And hopefully these recent rises and spikes won't set us back.
Can you talk a little bit, Paul, too, and we talked about this when we were discussing the show. One of the things that we've been hearing from clients is, to your point, a pretty quick return to, for most folks, anywhere between 60 and 80% in terms of elective procedures, but a real concern about what might be called the pipeline. So what does that look like 2 to 3 months from now? Because so much of what we would call the up funnel care, so primary care, diagnostics, preventative care, that also had been turned off. And to your point earlier, is much easier for consumers to put off, because it's one thing if, you know, I've got just drastic hip surgery and it's painful and I can't go up the stairs, I'm going to get that done. It's another to go, well, it's an annual physical, or it's my annual skin cancer checkup, or my diabetes check-in. I'm not coming in for that. And if there's not virtual visit option, all of that, we call it kind of the missing domino effect, where those dominoes that have to fall up front to drive, you know, surgical volume down the road, if those get taken out of the lineup, then you're never going to get to surgery. So can you talk a little bit about if you guys are concerned about that, or how you're kind of approaching that issue?
Yeah, so, you know, I don't think we have 100% clarity on future pipeline. We do have predictive models. And I think we're feeling very good 30 days out as we look through the month of July. And we can see surgical surgeries and appointments scheduled. We're also doing things to adjust our operations. We're encouraging our clinical departments to extend hours, start earlier in the morning, provide flexibility for our staff as well. Start earlier, offer hours that run later, provide weekend hours, to try to provide maximum flexibility. We're also doing a lot of education on virtual visits, especially for MyChart users who can do virtual visits now scheduled through MyChart. But it's we're also one other place we're seeing that's I think a good predictor is we've turned back on all our lead generating patient acquisition programs that are done through paid search, and we're seeing very strong lead levels. Now, what we're watching is conversions to see how those come in as appointments, but early indications are leads have really come back. And it's interesting, you were talking about doing the podcast during the height of COVID and then pivoting. Well, what we saw in our digital content, especially social media, all through March, April, into the very beginning of May, a high interest in COVID, and then it pivoted away and content for other diseases conditions returned, and the content of our health library. So we know that patients now are resuming looking for regular care. So I think, you have to adapt. This is where adapting the business model, really integrating virtual visits in long-term into the practice model, having physicians do direct outreach to patients. We've been ramping up a CRM that's been led by our Office of Patient Experience and our IT team, where we're using the CRM to message patients for return to care based on people who had previously scheduled activity and haven't come back. And so, as safety continues for the cohort that aren't coming back, safety is the primary concern. And sometimes that's a pre-existing medical condition or just fear. And that's the piece I think that's going to take some time.
Yeah, for sure. Reminder to everybody, if you've got a question for Paul or for me or for Chase, put it in the Q&A function at the bottom of Zoom. Happy to answer any questions as we go along. You mentioned virtual care, virtual visits. Just real quick, because I want to make sure we have enough time, and we've got plenty of time, not a concern now, but I know you've kind of got a passion point that you want to make at the end of this. I want to make sure you get plenty of time for that. But let's talk about virtual care and what you're seeing and how you think this is going to go moving forward. You mentioned it a little bit earlier, but let's hit on it explicitly here.
I think, we know virtual visits have been slow to develop in healthcare. And it's interesting, our past research and learning on this said it wasn't that, consumer satisfaction levels with virtual visits, net promoter scores were always extremely high. But what we would see is people do an online virtual visit on demand, but we wouldn't see them repeat. At the clinic, our virtual visit business prior to COVID was half on demand, express care as we would call it, and half scheduled. But there was a lot of resistance coming from our own physician community because they didn't know how to integrate it into their practices. How do you do it? How do you do that side by side with your normal in-person visits as they're taking place? So obviously we saw a huge spike during COVID, as everyone did. We had 200,000 virtual visits in the month of April, which is just extraordinary. Now we've settled back to virtual visits being about 25% of our outpatient visits. And now our clinical leadership teams are having the dialogue with each of the respective institutes of how do you integrate this into your business model? How do we help physicians schedule this? We've actually now fully adopted the Epic online virtual visit tool that's integrated into MyChart, so people can start to schedule virtual visits. We're still using the American Well platform for second opinions and for our express care type visits. So, it's been a big leap forward. The challenge going forward is to sustain. And really, I think we can now develop a lot more clarity on the use cases for virtual visits and being much more intentional about how people build it into their practice models. So that's really where we're heading now.
Okay. And then you mentioned 25%. I just attended an advisory board, to give a shout out to them. They put on a webinar yesterday, and they surveyed system planners who came to the conclusion that eventually this will probably settle at like 20%. which seemed low. That seemed low in terms of the potential. Everybody got really excited. 200,000 is insane, and we've heard that from other folks too. And obviously, as we open things back up, and you can get in, and you don't feel fear to see your doctor in person. But I got to say, I had my first virtual visit experience during this, and I don't ever want to go back. I mean,
Right.
The idea of not having to drive, not having to wait in the waiting room and read a 2012 copy of Golf Digest, there's nothing I can imagine that would want me to get back in. Even some of the things I'd have to do could be done at home, like a blood pressure and that kind of thing. So I wonder whether we kind of settle back in at 20 and we might be underestimating the desired demand from consumers.
I'm smiling because you clearly are comfortable not driving anymore. So that's
that's right. I've got a car for sale if you're interested.
But I think it's hard. I think it's hard to predict. But I do think that we've cracked a major barrier, right? The physician community and health systems around the country, around the world, the genie's out of the bottle. Everyone has experienced virtual visits. I think you're right. They work well for an amazing array of things. And I do think, it'll rise over time. When you think about where usage in the healthcare system lies, it skews older. They're the heavy users of the healthcare system. Younger, healthier folks have fewer visits. But the technology will only get better as remote monitoring tools can be added to the mix, and you can send reliable data to physicians, and it can be integrated into your health record. And I would stress, I think the simplicity of this, just like safety is the key to return to care, ease of use is the key on virtual visits. And it's not just ease of use for consumers, it's ease of use for physicians. They need to be able to seamlessly go into a virtual visit and have all the prep work done, financial pre-clearance, have all the information they need to have an effective visit. And they shouldn't be sitting there waiting for the patient who's struggling to log in, So, we've actually built content and tools on our website to provide guides to patients to log in. And then internally, we have playbooks for physicians created by our own physicians to educate them on best practices. So when it becomes as easy as checking in for your flight on your Delta app or then we will have reached another level. It needs to get easier. It just needs to be scheduling, financial pre-clearance, payment, and the visit need to be just as easy as a one-click on Amazon. At least that should be the ultimate vision, right?
Right. And obviously there's a lot of things that are outside of your control or any health system's control in terms of making it easy. The regulations are myriad. They depend on federal versus state. There's different kinds of regulations. Reimbursement is always a challenge. The payers wanting to own this space as well. So you're kind of fighting the payers in many cases who would rather direct folks to their virtual care. So it's certainly not a simple deal.
Yeah. And I will say health systems have a huge advantage because we provide an integrated continuum of care. And if we do it right, we should be the big winners in virtual health. You should want to come to Cleveland Clinic for your virtual health and not go to a third party that it's a one-off visit. It's like if you're an airline, you book on the app because everything from your frequent flyer relationship and all your preferences are integrated in. If you go to one of the third-party booking sites, it's not an integrated experience. So health systems, if they do it right, can really use it to build and deepen patient relationships.
Yeah, absolutely. All right. One more reminder: if you've got a question for Paul, for me or Chase, put it in the Q&A function at the bottom of Zoom so we can see it and we will answer those questions. Paul, one last talking point. So, we've covered a lot of different things. What do you think folks aren't talking enough about as we have moved through COVID, moving through it continually? And and we'll continue to experience kind of this no normal environment for a while.
Yeah. I mean, I think for me, the thing we don't talk about enough in healthcare communications and marketing is communication to our own caregivers. And the most important lesson I'm going to take away from the COVID experience was the impact that communications had in guiding our organization through this crisis. And our CEO was absolutely committed to this throughout the process, and we've now elevated the level of internal communication we're doing, and it's stayed elevated. So, just to give you an example, and I know many systems did this, but we communicate. We have intranets that connect all of our caregivers, and we really don't do any printed materials for internal communications. It's too slow and ponderous, and we're averse to paper anyway. So we started at the very beginning of the crisis doing daily emails from our CEO, once daily to all caregivers, once daily to our board, all of our boards. And we continued that really right up through the beginning of May. So all of March, all of April, into early May. We're still doing an average of 2 to 3 CEO email updates a week. And on top of that, we've been doing 2 videos with our CEO a week. So it's run the gamut from, we actually took over a conference room up here in our executive area, put a camera there so we could shoot him on video at any time. So some of it has been him doing direct reads to the camera. Some of it's been him talking to our head of pathology, nursing, Florida, infectious disease. We've pivoted in the recent weeks to doing messaging on the impact of racism on public health and talking to our caregivers about those issues. But just to give you some perspective, we've had our caregivers have opened the emails over 3.3 million times since March, 3.3 million email reads, 83% open rate on the CEO emails, which is way above any norm that we see. We've produced 25 CEO videos that have been viewed hundreds of thousands of times. And, we continue to really keep our finger on the pulse of what our caregivers are concerned about, whether it's been testing or masking or return to work policies. Just this week, we put out a message for the weekend about the rise in cases and what they should be doing as healthcare people out in the community. But I think for us to be effective outside externally, we have to be highly effective internally. And we have put as much or more effort into our internal communications. And I personally think it's going to have a long-term legacy impact on our organization, that our caregiver morale and our caregiver engagement is as high as it's ever been, probably during the most difficult crisis that we've ever faced. Yeah. I'll give you 2 more quick anecdotes. One was, as we were building the Hope Hospital, our surge hospital, we took Tom over and videotaped him, and he gave them an inside look at how it was all being built. And at the very height of the early days of the COVID crisis, he went up to one of our COVID intensive care units and talked to all of our caregivers there. Really a transformative moment in terms of building confidence that our masking and infectious disease control processes, we had confidence in them enough that he would go to that unit on his own. So as you could tell, I'm passionate about it. I think it needs a lot more attention from us as industry leaders and communicators. And we're hoping to invest a lot more in our internal capabilities going forward.
That's great. We just love hearing that. We've been talking about that for a while. It's been kind of one of the principal components is we've celebrated the workers and the physicians and the nurses as heroes, rightly so. But we have to support them as organizations, not just obviously during the crisis, but we're going to need them to be as great as they were coming out of this because of the financial situation that so many organizations face. And, I say this all the time, so some people probably get sick of it, but my wife is a therapist. She focuses on trauma therapy. And so her niche has been, frontline workers. That could be doctors, that could be therapists, that could be social workers. And so this has been kind of a passionate thing for me as well, because she's got me into like, this is so critical. It was critical before because it was never really addressed in the right way. And now here it is, like the number one issue for this field.
Yeah.
So just really glad to hear that you guys are doing so much and appreciate you sharing that. We have a couple of questions. Paul, are you still good on time?
Absolutely. Yeah.
Okay. So I'm going to go with the first one. And the question is, what are your plans regarding acute hospital at home? Is that like something specific for you when you hear that? I don't know if there's a word missing.
I'm not sure I know the exact definition of acute hospital at home.
Okay.
So I don't know if you want to, I'll try to elaborate on what that is.
We could ask for a follow-up from the participant. Okay. I don't want to call out the participant by name.
I mean, I would say in terms of, maybe I'll answer it this way. It may not get directly to your question, so feel free to follow up. We as obviously one of our goals as a health system across the health system in the country is to reduce length of stay. And length of stay for acute patients, whether it's transplant patients or valve surgery patients or cancer patients, is to reduce length of stay. Recovery times are faster. Infection rates are lower when we can get people home. So we are very focused on, we have a home health division of Cleveland Clinic, and it's an integrated part of the care that our institutes provide. So it takes many forms, and we do it for acute cases, but we also do it for chronic disease, especially working with EMS teams that go to people's homes to try to keep chronic disease patients out of the hospital. So again, this is an area where technology will help us greatly. As we can provide better remote monitoring for acute patients, the confidence in being able to treat them at home and manage them at home will rise over time. We do a lot of ICU remote monitoring. So we have the capability, but I think there's probably a lot more to be done.
Okay.
Yeah.
So next question. So put on your prediction hat. How are you predicting insurance, so private payers and CMS supporting virtual visits at the same level as in-person visits in terms of reimbursement?
Yeah, I mean, I think it has to happen. I think as an industry, it right from a regulatory perspective, it needs to be one of our highest priorities. And I do think we're going to continue to see forward movement there. The fact now that we have had such a huge level of trial of virtual visits, it's hard to go back. And I know that those discussions, unfortunately, in this country take place on a state-by-state, insurer-by-insurer basis, except for Medicare. But it's I think you have to give CMS and the government credit that they opened that up very quickly. They did a lot of things much more quickly during the COVID crisis, including approval of therapies and accelerating normal bureaucratic timelines. For example, here in Ohio, we have a local company that created a technology for sterilizing N95 masks, and that now seems like ancient history, but they got it approved in just a couple of weeks when the Ohio governor raised it right up to the White House. Those things are kind of unprecedented. So I think it has to happen. Hopefully people won't forget the lessons of COVID quickly. I think payment for virtual visits has to be addressed. I think another thing that people aren't talking about seemingly anymore is the supply chains for healthcare, and the fact that our supply chains lie predominantly outside the U.S. The critical swabs we needed for COVID testing were made in Italy at the height of the COVID in Italy, and it just shut down, or masks and gowns that primarily come from China. So I do think those are two regulatory areas that one manufacturing and regulatory, the other regulatory, that need to be addressed.
Yeah, and it's so crazy when you just start dipping your toe into all the variables. And Minnesota, where I'm from, I believe has parity in terms of reimbursement for virtual versus physician, but it's a minority. I mean, there's not, most states don't have that. I believe CMS, once we were out of kind of the emergency, remove all of the restrictions and just do what you need to do, we would have had to go back into a really long kind of period that's required to change the regulations. If I'm probably way out on a limb here on this. And my understanding is they just extended the emergency period so that they can take more, they can continue the benefit of all of this. It does make you wonder why we have to ever go back to the long, ponderous process that was required.
Unfortunately,
it's the 3-year thing, right?
Yeah, I mean, clearly this is the complexity in healthcare. The other part of virtual visits is multi-state licensing.
Yep.
The fact that how do you grow virtual visits? Well, if you could offer care, a provider could offer care at multiple locations, it makes it a much more attractive proposition, especially if you have a strong healthcare brand. And those things have been glacial in terms of change.
Yeah. Well, hopefully maybe it is a silver lining. It's what everybody always points to in terms of positives coming out of this. And we just need to hope that we sustain those.
Yeah,
positives,
for sure.
Like you said, and don't fall back or forget or all the other things that can happen.
Yeah.
But hey, I think we should wrap there, Paul. Thank you so much for joining us.
Oh, it's been my pleasure. Thanks for everybody who's listened in, and wishing everybody a safe and fun 4th of July weekend.
Yes, safe and fun. Both those things can happen. So you can have both.
Let's hope.
That. If you've got something you want us to cover, shoot us an email at nonormal@thinkrevivehealth.com. You can put something in the chat function right now before we sign off. We'll be back again next week, same time. Remember to visit thinkrevivehealth.com/COVID-19 for all of our content related to that. For a recording of today's episode, we'll also be there by the end of today. Remember to subscribe on iTunes or wherever else you are. And until next week, good luck out there in the no normal. And yes, have fun and be safe this holiday weekend. Thanks.